Hi, Dr. Bone here, and I've got a guest with me today, and this is Joanne Koecher. Joanne Koecher, you might remember from another video where we talk about occupational therapy, and you gave us a little bit of information the last time, Joanne, about your education. You said you went to the University of Missouri?
Yes, 1995 I graduated with a bachelor's degree.
And tell me a little bit about OT school. Is that a four-year education?
It was at that time. Now it's a doctorate. It is pretty vast. We actually have full-blown anatomy, neuropsychology. We have a lot of psychology, neuroanatomy. It's very vast and very detailed. And then we have some internships that we do at the end.
So it's gotten more intricate, more involved over the past 20 years.
Right. They now do more research than what we ever did. So it's more advanced in the doctorate program.
How has your journey through, taking care of others in occupational therapy, how has your journey changed through your career?
Well, when I first started, I was an independent contractor. So I would go out and wherever I was needed, I would work. Sometimes that would mean I would work in a school system and be an in-school therapist for a while. I worked in a brain injury program in which we did an outpatient program for those that had been through traumatic brain injury. I worked in skilled nursing. I worked in rehab centers. So it was pretty vast. I did hospitals. So home health.
So OT isn't just for frail people or just for elderly. You've done occupational therapy for kids.
Right. I did early intervention, which was, I worked with babies at one point and in the home so that I could train the mother and the caregivers on how to care and what needed to be done with the baby. There were some positioning aspects that we worked with in order to help with the growth or help with the neurodevelopment. And so I did a little bit of that one-on-one with the mothers and fathers, caregivers.
And then with patients that are traumatic brain injury, like somebody that maybe was in a motor vehicle accident, right. That type of brain injury or traumatic.
Right. The focus on that was not just body, but they're also the brain, looking at the cognition aspect. They may have short-term memory. They may not be able to remember if they brush their teeth or not. So we had to come up with techniques in which they could use to independently recall if they had completed their morning routine, because some would just kind of forget what the next step was. And so you had a checklist or some other form in order to help them carry out their EVLs throughout the day.
So little reminders for which activity they'd done and which one they'd completed, because kind of like, what's that movie?
50 First Dates.
Yeah. I don't like that movie because memory loss is really hard, I think, for the family.
Oh, absolutely. Absolutely. And they become so frustrated. So we try to help them too, not just the patient, but the caregiver too, because there's always a caregiver involved. Regardless if the person is independent at home, there's always family involved who are concerned.
So special populations.
Yes.
A lot of special population needs, whether they're young, they're middle life, they've had a stroke, they've had a traumatic brain injury, they've got a progressive illness, maybe a dementia for older patients. But a lot of special population work.
Yes.
How does a patient, or maybe if the patient doesn't realize they need help, how does a family obtain help for someone? How do they get an evaluation?
Well, first step is always with their physician, their caregiver, who provides overall medical help. Usually talking with their doctor, they will find some kind of connection. They can ask for a occupational therapy evaluation, and usually the physician will grant that. And from there we can go. We have resources that we use. Whichever company we're working for will usually have somebody who is in social work or handles that aspect, where to go to have outside sources in order to help with your care. We provide a lot of resources for home health, so home care, respite care, all those, we have names of companies and connections through those to connect people to.
Well, I know as a physician, sometimes I'll have a patient or a family, or maybe maybe the patient lives in a facility of a different level, whether it's IL, AL, or nursing facility. But I'll have someone tell me this patient needs a therapy consult. And so then the next thing as a physician, I need to decide, are they talking about a physical therapy consult or an occupational therapy consult? And I know sometimes I've just written a consult for evaluation and treatment, and I've not specified for a particular need. So when I write an OT, eval, and treat consult order, what happens to that OT, eval, and treat order when I send it to you?
So when I get that eval and treat order, I go in and talk with the patient and find out and review their medical records with them. And I find out where the biggest need is. If I see that the biggest factor is that they have low vision, then my focus of treatment will be toward the low vision aspect. If I find out that it's because they have something else debilitating, whether it be a degenerative condition or a progressive condition such as Parkinson's or a neuropathy that is going to affect the rest of their independence, in fact, that the progression toward home or just being able to stay in their home, then I work toward that.
So you really evaluate the patient as a whole person.
Absolutely.
And you talk with them about what they do on a daily basis.
Absolutely.
And then you try to make them functional and stay functional within their own environment.
Absolutely. We actually, when we talk with the patient, the first time I meet with the patient, I ask them, what is your goal? What do you want? What do you want to accomplish from here? And usually they're very forthright. Sometimes they come out with, oh, I don't know. I don't know. And then as we progress in our treatment, they are able to tell me exactly what their goal is. And so we work toward that.
So you talk with them about their priorities, their goals, and what quality of life is important to them and what they really want to accomplish. Absolutely. To be able to stay functional in their own home.
I had one person who asked me, he wanted to be able to drive, and he had a brain injury. And I was like, oh, I'm not sure about this. But we did work toward that. And he did eventually take his driver's license again and pass. So wow. I feel like that was a big accomplishment. That was his goal. I was a little nervous because I'm not skilled in totally that area, but we worked on other aspects of it to make him successful. So even though I'm not a driving instructor and I'm not skilled with that, in fact, people tell me I'm not a very good driver, but but I was able to work on the skills he would need in order to accomplish that goal.
And so then he had to go to the DMV to take a test and get a driver's license. That had to make him feel really proud.
It did.
And you really felt proud about him accomplishing that too.
Absolutely. It was one of the biggest achievements in my career, I think.
Well, tell me about some pitfalls. I mean, do you run into some things that are typically hurdles that sometimes you can't cross?
Yes. They can't see the horizon. They can't see that as we work and progress toward this, you will get closer to that being independent. They kind of have given up. Those are the ones that I have a hard time with, or the ones that we know there's something going on. We know there's something happening. It's hindering the progression, and the doctors nor the whole team, all of us, can't quite put our thumb on it, and it just takes time before it's revealed. And
so how do you communicate with the other team members? Because it sounds like when you go to do an evaluation, it's just you,
right?
And maybe just you and the patient, possibly another family member, but mostly just you and the patient working together. So how do you communicate your assessment and your accomplishments and those hurdles? How do you communicate that with the other team members?
Well, we usually have some sort of team meeting because I'm working for a company that we work together as a team. There's usually a nurse, Of course, there's a physician. We can't do anything without a physician's order or a physician to oversee. So the physician knows and will read through our evaluation, and they usually sign off on it right away, knowing that this is what the patient needs and is agreeable to it. And then we communicate, usually weekly, as a team regarding the patient progress or lack of progress or what their needs are. We also communicate on a daily basis regarding if there's an issue with the patient's health or if we have any type of concerns. So I may talk to my team leader saying this person didn't get up at all today, didn't eat breakfast. I'm really concerned, especially since they have low blood sugars or they have diabetes. Those things are real important. Or if they didn't take their medications, we communicate that. We're kind of the in-between. We're another set of eyes on the patient.
So you have a team meeting, and then you also communicate by a written method because I would think you have to have written reports now too.
Yes, we do.
You have part of a medical record system.
We do. And we also do phone conversations. So anytime I have a concern, I'll immediately call.
Okay.
Yes.
And then you write your note and you send that to the physician, and the physician has to review that note and then sign it.
Yes.
And then if you think another order is warranted, so I write for an evaluation treatment, and then you go in and you do your eval, then you would tell me, I think this patient needs this. Then you would send that to me, and if I review it, and I also believe that that's what the patient needs, then I can sign off on that, and you can proceed with that treatment.
Yes, we'll go forward with that.
So the patient can't really just call you up and say, hey, Joanne, I'm having trouble with my ADLs. Come over and help me. You need something from the physician.
Absolutely. We have to have a physician order in order to do that.
What is a typical day like for you? You get up, you comb your own hair, you brush your own teeth, you put on your uniform, and then when you get to where you're supposed to be for the day, how do you know where to go? How do you know who to see? How do you know what to do?
Well, a lot of times it depends on what I'm doing for that day. If I'm doing home health or a mixture of home health, outpatient, inpatient, I just kind of schedule my day throughout. The home health are based on what I need to work with on that day. If I'm working with them on a shower, of course, I'm going to be there in the morning. So they're going to be my first patients of the day. And I work with that. If I'm working with them with cooking, I'll put them more toward the noon hour and do a special cooking activity with them. And then in between that time, I'll work with the maybe those in the skilled nursing. I'll go in and work with them, trying to help them with their activities that they need to work on to improve their strength, their balance, their activity tolerance, that factor, their transfers, educating staff, those type of things. And then I go back to the home health. So it's kind of a vast day.
So you have to be pretty flexible.
Very flexible.
And have to be able to adapt to many different environments,
Absolutely.
It sounds like.
Absolutely. It makes for a very quick and long day.
Quick but long. Okay.
Yeah.
Tell me, what's a really good day?
Oh, what's a really good day? Gosh, is when something that you've been working on and trying to get the patient to do, and you've worked on it, and the patient just can't seem to do it. An example of that would be after a stroke. I've had patients who just can't move their left arm, just can't. And we've worked, and you just feel like, oh my goodness, you just want it to move. And you walk in, and the patient says, hey, look what I can do. It lifts up their arm. It's so wonderful. You just almost cry. It's just so wonderful. You just want to dance with joy. It is great because
the patients have to be excited.
Oh, they are. And it's just so wonderful. And you know that let's go now. Let's make it harder. Let's make it more.
And so then they want to achieve more.
Yes.
And I think that's an important point about strokes is many people feel like the damage from the stroke is permanent.
Yeah. And it's not. And we used to be told, I remember when I was a new school student and we were learning a lot about strokes, we were told that if they didn't get any movement within the first year, then it was not going to happen. And through the years that I've been a therapist, that is so not true. I've had patients that are 5-year post get new movement. There's new things going on in the medical field that has helped people get movement again. So
keep working, keep
working,
trying,
keep
and
trying.
keep going and not quitting. And
Mhm.
every day is a new day. And certainly setbacks occur.
Yes, they do.
And there are days that are not so successful. But
Mhm.
if you just keep working, keep trying, the brain is an incredible organ.
Amazing.
And when I talk about stroke to a patient or to a family, I talk about the bullseye effect, that you have the center part where the stroke occurred, the surrounding cells that were kind of injured but maybe not terribly damaged, and then the outlying cells around that, which may be normal. And then in the first couple of days that the stroke evolves, and so sometimes that bullseye, that center of that bullseye, seems like it gets a little bigger, and they might come in with one level of not function, and then on day 3 it seems like it's actually a little bit worse, and I tell them that's just the normal evolution of the stroke. But what you have to do from here is you have to work with your therapy department so that the surrounding cells that were not injured can learn how to do those tasks.
Absolutely.
And when you teach those other cells, this is a new way for you to work, that's where your therapy department come in, and they can really help that patient find that success.
It's funny that you're saying that, because one of the things I tell my patients is that it's like you're going to work and you're driving and there's a big pothole and the road is closed. So they've rerouted you around a whole new part of the city that you've never been before to get to work. So you drive and it's so slow and you make so many wrong turns. You have to turn around until you finally get to your destination. And the way home is the same way. You're just not right. It's one-way streets. Everything's confusing. And you finally get home. Well, that first trip was terrible. And then it gets next day you have to do it. It gets a little bit faster, a little less wrong turns, and eventually it becomes a lot faster, but you're still going around that pothole, but you're able to get there without thinking. That's how I tell my
I love that.
patients.
I love that. Well, tell me about a difficult day. Have you had some tough situations that you've had to go through that you might be able to share with us?
Oh, a few that I can pick out. Some of them are, most of them are when you've worked with a patient and they're doing very well, and just slowly progressing, and then they may come in with a new diagnosis,
another event or a new diagnosis,
and which is a big factor in which whether or not you want to proceed anymore.
So you build that relationship with them, and then something else sometimes happens.
And sometimes it's even with family. Just recently, we had a lady who was doing just so good, progressing, and her daughter died suddenly.
Wow.
And she gave up. She didn't want to work anymore.
Yeah.
So,
yeah.
I mean, there's other factors that come into play.
So it's very complicated. Have you ever been in a situation where you're caring for someone and you kind of get stumped and you're not sure what's the next step? Where do I go from here?
Oh, absolutely. When you come to that set where you've tried everything that's in your bag that you've worked with all these years and it's still not working, then you just kind of reach out. I reach out and network with the rest of the therapists I know, and it may just not only be the occupational therapist, it may be the speech therapist, physical therapist. We bring our minds together. They bring what they know. I call the doctor. We all put in what is the block? What is going on? What is happening? Why are we not making progress?
So sometimes you hit those roadblocks too, where you have to think about what's the next step. I'm kind of jammed up here.
And sometimes it may just mean it's a plateau where I need to just step out, give it some time, and then whenever it shows a little bit more hope that there's some more progress that can be made, I come back in.
Okay.
So sometimes it's just not all at once.
You got to give the patient a little time to learn that new path around the pothole.
That's right, that little pothole.
How do you find refreshment? How do you stay happy and joyful in a job that sometimes can really seem like there are some roadblocks and there are some hurdles that can be difficult?
Well, I know this past couple of years, 2020, and all the changes in Medicare and how we treated was one of the biggest roadblocks I think that have happened since I started my career. You just stay focused on trying to help someone else, trying to help their life be better. You try not to focus on yourself. It's hard sometimes, but when you see that how someone is so much better than what they were before, when they were at their lowest, and now they're able to function and live, it's just
Very fulfilling.
Very fulfilling. Yeah.
Okay. Do you have tips for the caregivers for these patients that, maybe have had TBI, traumatic brain injury, that maybe have a dementia problem, that have had a stroke and then had another stroke, that maybe this is as good as it gets, and we know from here that we're probably gonna experience more decline, like a cancer patient.
Right.
What tips do you have for those families, for those caregivers?
Well, first of all, make sure you take care of yourself. You have to keep in a good space. So whenever those times come when you're feeling overwhelmed, you need to take a step back, call in some help, let someone else take over, and it's okay to do that. What we have found is that most families feel like it's their obligation, which I understand that totally. But it's also your obligation to stay in the right mind so that you can be there for your loved one. So finding outside help to come in, even if it's for a couple hours, and give yourself a break. Give yourself a break.
And I know that's something that we talk about sometimes with palliative medicine and with hospice medicine, is we have volunteers that will go into the home and provide maybe an hour to 3, possibly even 4 hours of company for that individual. Maybe not caregiving, but maybe to play a board game, to watch a movie, to share a meal with, so that the family member could go shopping, get a haircut.
Yeah, just get out of the house for a bit. A little bit of freedom. So they have that obligation where they feel like they absolutely have to be there 24/7 to watch over the loved one. And when you have that, you have no freedom. So telling yourself you're going to allow yourself that time to go away so you can have a breather, it just rejuvenates you. It rejuvenates the person to be able to come back and handle that again.
All right. So it sounds like you really enjoy your work.
Oh, I do.
You find it very fulfilling. You have seen a lot of changes.
Yes.
Over healthcare since the mid-90s when you started as an occupational therapist, but you still find joy in what you do.
Right.
I know that as a physician, I've seen many changes, and I've also feel like big business kind of has taken over healthcare, and I too really enjoy the patient relationship and seeing their successes, and then trying to be with them during those transitions and those transition times, and being a support for them. And that's what I hear from you, that you may not be able to achieve that patient recovery to that prior level of function, but you enjoy every little success and celebrate that with them.
Absolutely. I become part of the family, and I enjoy that. I help with making that decision in order to make that transition and tell them it's going to be all right to do that. Sometimes giving them permission. Sometimes they feel like they got to continue to fight. And when you know that they just need to continue to live, and it's not about having to keep working toward this higher level that they may never be able to achieve again, but to be able to continue on the level that they're at and just keep that going.
so that there's some satisfaction and there's some comfort, and it's not always a battle.
No, not always a battle. So
We want to struggle, we want to fight, but we don't always want to be at war.
no, and sometimes our bodies, we're just at war with ourselves. So for our patients, it's sometimes comforting to them to be given the permission. It's okay. Just it's okay. We don't have to get anywhere further. This is perfect. So.
Well, I really appreciate your time again today. Any final words in closing? If somebody was thinking about, oh, I want to be an occupational therapist, I want to learn more about it, how would a person learn more about occupational therapy? Do you have a society or?
Yeah, we have an American Occupational Therapy Association. You can research it. It's American Occupational Therapy Association.org. And they have so much information about occupational therapy.
Sounds like you have a career where you're pretty independent.
Yes.
But you get to work with people
Yes.
on a one-on-one basis, sometimes in small groups.
Mm-hmm.
And that might be very satisfying as an occupation for some people. And Joanne has certainly enjoyed a lot of success in her career.
Mm-hmm.
I appreciate your time again today.
Thank you, Sarah.
You're welcome.
Bye-bye.
Bye now.